Hi, welcome to Viewpoint, and thank you for joining us. Susan Solomon, my co-host, and I started Viewpoint to help people know what resources are in their community. And I'd like to introduce Susan Solomon, who is the Director of Drug Crisis in Our Backyard, Executive Director of Drug Crisis in Our Backyard.
Hey, Lily. It's nice to be here. It seems like we haven't been here in a few weeks.
That's right. And our guests today are Aynisa Leonardo from Long Island Center for Recovery, and Jim Amand, who is the Director of Provider Relations. And Aynisa, I'm sorry, you are the Director of Military Services for the Long Island Center for Recovery. I got it.
And it's Jim Amand.
Didn't
Jim
I say that?
Amand.
Okay. It's close though. It's close.
You told me how to say it, and it went right out the window.
So Long Island Center for Recovery. So that is, where is that actually?
We're located out in Hampton Bays, Long Island. LICR, Long Island Center for Recovery, and I'd like to include the Florida Center for Recovery as well, FCR. LICR was founded back in 1995 by a gentleman by the name of Jack Hamilton and his wife, Sean Hamilton. And we are a medically supervised detox program and rehab treatment program. It's a 50-bed rehab treatment program with a medically supervised detox. The Florida Center for Recovery, which was also founded by Jack Hamilton and Sean, which is actually run by their daughters, Shay and Elizabeth Slane, was founded in 2002. That is a 72-bed co-ed facility, medically supervised detox and rehab and residential program down in Florida.
Now, when you talk about New York and talk about Florida, there's a lot of controversy about sending people down to Florida. So can you tell us just briefly about your program and why people should send their families to you? What makes you different than the other ones that are down there, if you can?
Well, FCR, Florida Center for Recovery, was founded back in 2002. So we've been around almost 16 years. And you're right, there has been, unfortunately, and it's not only Florida, this has been going around throughout the country. There's been a lot of unethical practices going on in Florida as well as other states. And unfortunately, it's starting to move up to New York as well. But FCR has been around, as I said, 16 years. It's on 12 acres of land. We are a standalone medically supervised detox rehab residential program. So it's not a program where clients are living in one location and then being transported to another location, whether it's for IOP, sober living. They are all living on one campus. They live in rehab treatment program, and all the treatment activities, the therapeutic activities are all done on the same campus. So.
It's kind of interesting because I know some people that have gone to Florida to get clean, and one of the model that you were talking about, having housing off campus and driving them to the clinics after an inpatient stay of, let's say, 20 days, and then moving them off campus. How is that a problem? Why is that a problem? Because you made a point of saying this was self-contained and you're not moving them off campus. So why is it a problem when they use that other model?
It's not a problem if it's an ethical program. And let me be clear, there are some really good ethical programs down there that are the PHP IOP model. However, individuals have gotten into this field for a couple of different reasons. One, because they want to help people, and stay focused on helping an individual get clean and sober. Unfortunately, there are others that have got into this field to help others, and then have realized that it has become a money machine, a money making machine, through the billing and the insurance and the out of network and a lot of different factors. And then others have just realized that it's just about making money. So, our theory and our foundation, our true foundation is let's get them in a standalone treatment program, detox, rehabilitation, and residential. If you can provide the residential program, get them a 30 to 45 day treatment program. Get a foundation of at least some abstinence and early based recovery. And then transition them then to the PHP IOP program when they're ready to be a little bit more independent. Thank you. What we're seeing is clients are either being detoxed and then diverted right to these PHP IOP programs, and they're really not ready to be in that independent environment.
Right.
You want a transitional program that helps them to transition successfully.
Yeah.
And so do you have that in Florida? I mean, after they do the inpatient stay, 30 to 45 days, which is a long time, how are you getting that? How are you getting those lengths of stay?
Through the insurance companies, for the most part. There's different billing practices when you can bill. In New York, for the Long Island Center for Recovery, we are contracted on an in-network basis.
Right.
So we have contracts with all the, we're privately owned, and we work with the private insurance companies or the commercial insurance companies. So we have contracts with all the insurance
But you don't get
companies.
as long a stay as you do in
It's a
Florida.
28-day rehab, and we do get shorter, and it's in-network.
Correct. We're designed for 28 days.
Right.
We're getting on average, with the new
21,
legislation
22.
kicked in back in January of 2017, I'll be the first one to admit it has helped in ways, but it has fallen really short in ways too.
The 14 days, you mean?
The 14 days.
The 14-day authorization without prior authorization.
Correct. It has benefited some and it has hurt others. So we are probably getting a little bit more of a length of stay, 17, 18 days in general,
That's
which
not
is far
Not
short
bad.
of what needs to be done.
Right.
When you're out of state, whether it's New Jersey, Pennsylvania, or Florida, you can utilize what's called out-of-network benefits. And with the out-of-network benefits, there's a little bit more flexibility in terms of the billing process and the length of stay.
Right.
So that's how we get the longer length of stay.
Okay, and then so then after that 40 days there, is there somewhere in Florida that you do IOP so that they then can not have to come back? What we find is people are coming back here and they're ODing. That's is the story over and over and over again. So.
Yep, we work with a couple of really good, probably 4 or 5 really good, solid PHP IOP programs down in Florida that will transition out of the detox rehab residential into the PHP IOP program. Very well managed. The treatment is excellent, and they're monitored very closely. And we vet all the treatment programs that we work with. As we want them to vet us, we go in and we vet them. We go down to the locations. We want to see we want to make sure that what they're telling us and they're telling our clientele is what they're going to be sent to.
Yeah.
Now, when you talk about up here, because you're Director of Military Services, so can you tell us about what's going on up here at Long Island Center for Recovery? There you go.
So we have 50 beds. We have 10 detox and 40 rehab beds, and the military program is a small section of that. We do work with some specialty populations, so that's one of them. We also work very closely with union workers as well. So, what's special about our program, first of all, just to piggyback off of the discharge conversation we were having, we have a full-time discharge coordinator that does purely that. So our aftercare is really just as important as the treatment we provide while they're with us, which is huge, because I agree with you, those premature discharges lead to the relapses that we're seeing and the overdoses. So we're trying to get ahead of that and really just treat each case individualized, thorough, give them comprehensive treatment and also make sure their aftercare plan matches that. So his binder, he has a binder this thick of all different resources that we use, which is great. That's unique about us. And then we have other services that are unique. We do trauma specialty services. Rapid resolution therapy is something we do at both locations.
What's that?
So it is a treatment modality that was founded by Dr. John Connolly, who works down at our Florida Center for Recovery. And then he trains other clinicians in using that technique. Now, we have 5 clinicians currently trained at LICR that use it as well. And it's, how would you describe it, Jim? It's it falls under the category of kind of like an EMDR, but very different. And I'm not trained in it, so I don't want to give it a disservice and explain it the wrong way. But it is kind of like a thought reframing technique that within one session can make huge differences for a client. So we use it, especially because we're a short-term program. We want to make the most change in the shortest amount of time, which is why we implement that as often as we can. I mean, every day we have that practice being used. And there's other services we do as well. We have a biosound bed. We call it a serenity bed. So there are things like that we have the clients use daily as well. That's been really helpful. And basically what that is, it's a bed that has vibrations built into it that kind of targets different energy centers to do detox, anxiety reduction, target negative thinking patterns. So it's paired with like sound and It helps people to downregulate and also kind of like develop the insights that they need in moments that they're either stressed out or just they're at that place of treatment where they need an alternate method. So we have services like that. We have, standard CBT, DBT, relapse prevention. We have AA and NA every night. I mean, it's a very thorough clinical program, which is really great. 9 a.m. to 10 p.m. every day we keep the clients going. So there's a lot that goes on within that. So in 14 days, you can make huge strides, really.
And one of the uniquenesses of LICR, as well as FCR, but LICR in New York State is being a medically supervised detox program. We're one of probably maybe 4 or 5 in New York State that can do the medically supervised. There's different levels of detox that can do the medically supervised detox right in the program. So they don't have to go to a hospital setting. They can, but they don't have to go to a hospital setting and then be transferred to LICR for the rehab treatment. We can do the detox protocol right there, as we can down at FCR as well.
You know, the hospitals are not doing a very good job with this, let's face it. They're turning them away when they come. And when you talk about, I work with families a lot. I'm a grassroots nonprofit organization, and so I work with a lot of families. And because we don't do treatments, but we do referrals. And what I hear families calling me in crisis saying they're trying to get their kid into a detox, and what they're hearing is they can't because they're not in detox. Could you address that?
Yeah, a lot of the hospitals in New York State will turn clients away until they're in active withdrawal. For whatever reason, that is, I don't know if it's some type of regulation that is in New York State. I'm not sure. LICR will not turn you away if you're not in active withdrawal. We will take you in, and then once you are in active withdrawal, we will start to, there'll be a full medical assessment, and then we'll start to put you on the detox protocol. Depending on what it is. If it's opiates, we use the Suboxone. If it's alcohol and benzos, we use the Valium. We'll bring you up to a comfortable level and slowly titrate you down within the 5 to 7 day detox protocol. So we will not turn them away.
All right, that's good to know.
One other uniqueness that we have done, Jack Hamilton, the philosophy was always bring them in and we'll figure it out. Obviously, things have changed throughout the years. There's more variables and barriers with insurance than there were back then. But we, within LICR and the team, we can usually bring a client in within that day, if not 24 hours.
Got it.
It's huge.
And
That's
which
huge.
a lot
You
of
have to wait
facilities
3-4
can't do
days.
what we can do.
Right.
Unless there is as I said, another barrier in terms of insurance and co-pays and deductibles, and because that has changed too. And we're seeing the increases now with the new policies kicking in January 1. We're seeing the increases of deductibles and co-pays that were $250, now are $2,500, that were $500, now $5,000. So that's another barrier to treatment, unfortunately.
But we take every phone call very seriously, and that goes for us and also our admission department. Any phone call coming into LICR, if right off the bat we know it's a case we can't take, we keep that person on the phone and we make sure that they get a proper placement. And I think that's a lot of what drives the epidemic as well, is calling places and then not getting the answer you want and not knowing where to turn.
Exactly.
So like Jim said, we're built upon the philosophy that we need to help every single person that comes to us, whether or not we can bring them in, or if we can't, give them the proper resource.
So now, are you on Oasis? Their bed availability program. Are you on that? That's
yeah, we're Oasis licensed and JACO accredited, so I believe we are on their site.
Oh, right.
Yeah, and we actually were when LICR was founded, we were a 40-bed facility. Oasis came in just about a year and a half ago and asked us if we'd be able to expand our bed space.
Wow.
So with the help of them, we walked around and reconstructed some rooms and conference rooms and offices so that we can expand from 40 to 50 beds.
Now, where do they go after they finish inpatient rehab? Do you have outpatient as part of your program?
We do.
We do, but it's for people that are local that can access it.
Right, okay.
And honestly, a lot of our referrals are coming more from like the city, the metro area.
Got it.
So then we're going to refer them back to that discharge coordinator with the binder.
Got it.
He places them somewhere.
Okay.
So we do have outpatient, but that's for really the people that are located near the facility.
Every client during the process of being in treatment, they'll start their discharge planning.
Yep.
So each client will have a discharge plan, which includes an appointment set up with an Oasis licensed IOP program.
Got it. And how long is it taking before you get the appointments? Because being discharged from inpatient, you're supposed to get it within 7 days.
Yeah.
We
have a close relationship with most of the IOP programs that we work with. So we are getting them certainly within the 7 days, if not
Usually
within
sooner.
2 or 3 days.
Yeah.
And working with some of our IOP programs as well as our medical staff, we've also incorporated the Vivitrol shot.
Good. Good.
Now it's not for everybody. There's a full medical and clinical assessment while the client is with us in terms of how are they responding to treatment. Are they following all the rules and regulations? I don't want to make it sound, that it's restrictive, but are they following the treatment protocol? Are they willing to follow through with an aftercare program? We have clients that come in and say, listen, I really want to get off the opiates, but I think I'm going to continue to smoke pot. Right. Well, then, for us, they're not a Vivitrol candidate.
Okay,
so
why?
What? Yeah, right.
Because we look at the fact that Vivitrol can be a harm reduction medical, medication management treatment. However, we look at it as an abstinence-based component as well. So we want them to be, at least the philosophy is total abstinence by the time they leave treatment, which they will be, but understanding that following through with the total abstinence and abstinence-based medication-assisted treatment.
Is that the same protocol used for Suboxone? That they have to be engaged in treatment, and is it the same philosophy?
We don't initiate Suboxone on discharge. We use Suboxone for the detox only.
But I know for programs, usually they do require that, but that's not something that we do.
All right. So you don't, while they're with you, that's it. Got it. Okay.
They don't go home with anything.
Got it.
We keep them, we titrate them off of everything.
Everything within the 7 days. So it's an abstinence-based program.
So the Vivitrol is when they're leaving. It's part of their discharge. When they're hitting the streets. Okay, the real world. Got it.
Do you give them doctors where they could get Vivitrol when they get to wherever they get it?
Absolutely. Yeah. So if we initiate it, then that's part of their aftercare is making sure that they're set up with a program that follows up with that.
Yeah, because we're hearing that people can't get the Vivitrol or the Suboxone. They're getting it in a place and they leave with a prescription, but then they can't find a doctor that's willing to prescribe it when they get home.
More often it's an outpatient program that does it that we're referring them to. So we work closely with the outpatient program. Specifically, if we have a Vivitrol client, we're going to make sure they go to one of those programs. Right. Some of them do it, some of them don't. We know which ones do and don't, so we can navigate that. Yeah.
Okay, good.
Sounds like you get them covered all around. What about families? How do you integrate families into treatment?
We do. We have a family program that is on Saturdays. We incorporate 2 family members per client, being 50 beds, so we allow 2 family members to come in. It's a full program. It starts at 1:30. It's not visiting. They have to, if they want to come out to on a Saturday to see their family members, they have to participate in the family program. We separate the clients and the family members, and we kind of do an educational component in 2 separate groups for about 45 minutes, and then we bridge them all together.
Got it.
And we do a full bridge group with them for about another hour, hour and a half. And then at 4 o'clock, the family members are allowed to stay from 4 to 5, and then they are also allowed to stay for dinner, which is at 5 o'clock.
Wow, sounds like a nice program.
Yes.
Real, like it's pretty comprehensive, that you're taking everyone into consideration.
It is. We also have a family therapist, so if it's difficult for a family member to get out on Saturdays, because we know that a lot of family members work, in today's environment, people do work on Saturdays, they have children at home, we can do family therapy, individual family therapy during the week, as needed and as necessary.
Some cases really require that, so that's why we're able to do it individually. And
most cases really
They do.
require that.
Really?
Because
Right.
the families
They do.
this is a family disease.
That's
yeah,
right.
and they're coming in crisis, so
That's
it's
right.
The families don't know how to deal with it.
They
They're
don't.
not changing when the people come home.
That's right.
And so that's why there's so much relapse and there's so many triggers at home. And really that getting that word out that families need to be in therapy while they're qualifier, let's call them, their qualifier, is in treatment is so important because they, even if they're not coming together and talking about it, at least the family's getting educated, working through some of the resentment, the anger, the frustration, the especially if they don't understand the disease because they don't have it.
Right.
So anyone that has this disease understands what it feels like to crave drug or alcohol. But if the family doesn't have it and just their child has it or their husband has it, they don't care. It's impossible really to understand.
And they're part of the aftercare no matter
right.
what.
And no matter what,
Right.
exactly. So it's so very important. We really are pushing that in our, whenever we go out and talk to anyone. It's like, there's should be someone here who is with families doing therapy with families on a regular basis,
right.
like weekly. It's covered.
Yeah.
And if I can just clarify the difference between LICR and FCR, between the 50 and 72 beds, they're both co-ed. LICR is designed as a substance use disorder program that does tie in some mental health, mild to moderate depression,
Right.
anxiety, bipolar, where FCR, the Florida Center for Recovery, is substance use disorder, co-occurring disorder,
Okay.
mental health that does have some substance use use disorder. We can do some psych as long as there is some substance use
Right.
disorder. We also have a pregnant woman's track down in Florida, which is very unique and which most programs don't have. LICR can work with pregnant women too, depending on where they are in the pregnancy and what they're using. FCR, they have a full medical department, and they work closely with outside OBGYN and the hospitals to work with women that are pregnant.
So how long do they stay down there? They can stay the same 45 days?
So it's a track, but it's within the same program.
Got it.
Yep.
Right.
You know what? Because I'm thinking about a young lady that was in outpatient, homeless, living at the VOA shelter, gave birth, and the baby had to be detoxed from Suboxone.
Right.
Wow.
And the baby had to stay in the hospital, and she's living in the shelter.
Right.
So that's what made me ask.
Yeah.
So what happens if a mother is during treatment, she gives birth? Does the baby and her come back to the Florida program?
We haven't had that happen.
I haven't
Oh,
had
sorry,
that happen.
okay.
We
Well,
haven't.
that'll
I
happen
don't
next.
think we've had that happen. I would say that. I mean, obviously, women can give
Birth whenever.
Whenever.
Right.
So I guess it does depend on where they are.
There'd be
in
more
their
medical
pregnancy.
involvement, I'm sure,
Yeah,
than what we
yeah.
have.
But my guess, to answer your question, is I guess they would probably stay in the hospital, and if she was discharged, she would probably, if we could take her back,
Right.
we certainly would take her
Right,
back.
got it.
At least get her back into the program
Right.
until we can find the next level of care for her. We're not going to just leave her
Right.
outside.
And-
we're going to take.
And
them
you
back.
bring the baby. Let's say the baby was fine and healthy.
I can't say that we would bring the baby
Okay.
into the
Okay.
treatment
Just was
program.
wondering.
I can't say that. Yeah, I'm not sure if we're
Because there are very
set up
few
for that.
programs for pregnant women.
Yeah.
It's true.
Very
It's
few.
true.
And then when they give birth, there's no shelters, really.
Right.
Right.
Except the ones that are here that are.
Right.
Right.
My guess at that point, we would probably
Sorry.
find a treatment program that we can transition them to, because usually at that point, I would guess that there might, I would hope that they're kind of at the tail end of,
Right.
of the, certainly the detox, the rehab, the residential, and then we can transition them to, like more of a PHP, IOP program that has sober living, and that can work with somebody that has a baby.
No, I was just going to ask, you were talking about something about trauma coming up.
Sure. Yeah, and just to touch again on the uniqueness of it, and it ties in with the
Please.
trauma. So I don't know if you had noticed my credentials. I'm an LCAT, so that's a licensed creative art therapist. So we do incorporate the arts, music, drama, cinema therapy, different avenues like that, and that ties right into the trauma, because trauma is actually stored in the part of the brain that it's hard to access verbally. So we bring in all this expressive stuff to try to get people to express it differently and get in touch with it differently. So, it's a trauma-focused program. The therapists are trained in how to treat trauma, but we also have modalities that allow people to release that trauma a little differently than just the standard therapy. So that being said, we try to make treatment enjoyable. So I don't want to say fun.
You say
Is that
fun.
okay?
Yeah,
So
fun.
trauma treatment,
Right.
addiction treatment, that's not fun. That's difficult for
Right.
people.
Right,
We try to
very.
make it so it's like enticing to them,
That's
where they
right.
want to get better.
Right.
And we have spiritual services we bring in. We have like a Tibetan singing bowl group we bring in. We have fire pit ceremonies where they're able to release some of the things they want to let go of. Music, art. I mean, they're things that people are like, wow, I'm enjoying this.
It's okay.
And I'm sober.
Right.
And I'm letting go of this trauma
That's
that's
right.
been there my whole life. I didn't know that was possible.
That's right.
So it definitely helps us in terms of being unique and being something that leaves a lasting impression on somebody.
And it also helps them get sober.
Yeah.
When they have all these positive things going on and they enjoy, I can even say you can enjoy treatment. Right. You can enjoy being sober and learning new experiences. Learning, Susan and I were talking about when you start using, you stop emotionally, growing,
yeah.
right? And now you have big guys and women who are really 12 and 13, and now they're learning how to talk to each other and how to express themselves appropriately.
I was interested in what you were talking about, the group you ran where it was a social 40 minutes, where all they had to do was have a conversation with each other and maybe have some coffee and cake and not talk about drugs. And that kind of sounds like such a really great group to me, because They talk about their addiction and relapse and all the triggers. I mean, there's so much conversation around that in group. And to now tell them, look, for 40 minutes, we're just going to hang around here and we're going to have conversations with each other. And that probably is quite the learning experience for people that are going through rehab, and I think it's a great idea.
And it's very, I'm sorry, go.
Yeah. I was just saying, connecting with peers outside of the addiction.
That's right.
Yeah.
So they're all connected through this addiction,
That's right.
but then connecting in a different level.
Right.
I
At a
mean,
different level.
They lose the connection in the addiction many times.
That's
so
right.
in recovery, they have to rediscover it.
Yeah.
And that actually goes back to, so I do a lot of the veteran services, the military services. We have peers incorporated with that as well because it's so important. So we have one of our counselors is a retired firefighter. We have a Vietnam vet. The peer connection for the veteran clients, but also for all of the clients is very important at LICR. We even have a, what do we call it, like a peer-run community or government?
Yep, peer group.
A peer group where they self-govern the group because that connection, they're reforming that. They're learning how to reform it.
Right. And how to talk to people. And that, when I ran that group up at NIAC Recovery, that was a group they were most afraid to go to.
I'm sure, yeah.
Because to socialize and not talk about drugs or trade sex or anything else that you do to get your drugs, to have to sit there and ask someone, well, can I get you a cup of coffee? How do you take it? Like, I don't know, I can't.
And it's interesting you say that because Jack Hamilton, one of the most important groups, he obviously believes in CBT and DBT therapy, or did. Jack passed away. He said, I want to incorporate this peer group because it allows them to sit around by themselves without any clinicians, without any oversight, and get them to start communicating with each other, and giving them the authorization and the kind of the seniority to sit around in a group. And we have a president, vice president, secretary that kind of leads the group, and it really allows them to take ownership. We allow them. We want them to take ownership of the facility while they're in there. Like, so you're living here, so take ownership in it, and it also allows them to express their feelings, their emotions, whether good or if they're frustrated and they're having a difficult time.
Fear comes up a lot.
Right.
With
Fear
peers.
comes up, anger comes up,
Right.
and listen, you're in a group with 40 or 50 other alcoholics and addicts. Not everybody's going to get along, and it allows them to express their feelings, and it is contained. Every once in a while, we might have a therapist in there, kind of, for oversight. And if there is some concerns within the facility that the clients have, it's addressed.
Right.
It will go to the president, vice president, or secretary, and then they will address it with the clinical supervisor or program director. So we really want to incorporate the ownership and allow them to start.
Sounds really like a great program.
Great program. We have to
very
go out to
impressed.
visit in the summer.
We
Please
will
do.
come out to visit in the summer, and then we'll
Good.
go
Please
to the
do.
beach.
Please do.
Yes,
We'll go to the
absolutely.
beach. Are you on the beach?
We're
We are
near it.
close to the
Near
beach.
it.
Can you smell the ocean?
You can smell
there
the ocean.
You go.
And at night when it's
you hear
real,
it?
you can hear it.
That's
Okay,
great.
great.
You have to come
Right,
back.
If you don't, we'll put a
sounds
shell
like-
up to your
There you go.
Sounds like a great program, and we're so happy we learned more about your program
right.
here today.
Well, thank
Thank
you
you
for
for
having us.
having
We
us.
really
Kidding?
appreciate it.
Great.
And if you have any
Great.
questions, you have our information, you have our contact
Yes,
information.
absolutely.